All right, I think we'll go ahead and get started. Welcome everybody to our medical providers update for March 3rd. Hopefully you can see my screen and we'll just jump into our presentation. Just in terms of agenda, we'll just go through our metrics. I'll discuss some state and national trends. I know that there has been some movement towards trying to harmonize state and CDC trends and reporting in an effort to simplify the strategy for pandemic response moving forward. And even the term pandemic response seems a little bit dated because I think that what people are really trying to construct is an endemic response. And I'll talk a little bit more about what that's going to look like for California when we talk about that. I'll also discuss some CDPH and executive orders, which might or might not pertain to what you do, but I'll try to help you find where you can get that information if you and your team need it. And then we'll end with therapeutics and vaccines. So in terms of trends, this is what seems to be going on in our region and really across the state. The numbers continue to look pretty good. This is the R effective number that we've presented before. R effective is a measure of community transmission. It looks really good. And this is basically, in my opinion, the most up-to-date site for looking this up. It's the state website called CalCat. And here it shows that the R effective is 0.69. Anytime it's below 1, that's really good. It means that transmission is slowing down. And you know, here you can see that the transmission started to slow down for our region all the way back in mid-January, but there was just so many numbers that we still experienced a surge through January and much of February. But in the last few weeks, we've actually had a pretty good slowdown in terms of the number of cases. And that's reflected in this long plateau below an R effective of 1, which is why we've seen so much of a transition to talking about lifting some of the restrictions and moving into an endemic strategy. As long as this number stays below 1, we can be assured that an endemic strategy is the way to go. If it ever pops up above 1, it means that we're basically going into a surge. And then, you know, as a society, I think we'll have to decide how aggressive we need to be in terms of shifting from, you know, an endemic low level, low aggressive strategy to something that's a little bit more restrictive in terms of activities. At the hospital level, here's what seems to be going on. We had a peak way back in January, and the peak has been kind of coming down rather nicely. We now have 230 individuals in our hospitals here in Fresno County. And then in our ICUs, again, the peak was around 100, and that has now fallen all the way down to 43. Hospitals still remain quite busy and impacted with non-COVID volumes, which again, that's been my constant complaint, is that a lot of these COVID dashboards don't really give you a sense of how busy the hospitals actually are. And that's really what the general public and the policymakers look at whenever they think about lifting restrictions, but they don't seem to understand that we just have a really lean, often impacted hospital system that's fragile even on a good day. And we just need to, you know, be very mindful and cautious whenever we make adjudications based on just the COVID numbers without looking at the whole system. In terms of what's going on around the state, again, you can see that the numbers look really good. All of these are downtrending numbers. These are from Dr. Galley's press conference that he did, which just showed that cases, case rates, hospitalizations, and various other metrics are all coming down from mid-February to the end of February. And that's why they sort of decided to move forward with lifting some of the masking restrictions related to indoor masking and with schools. Cumulative death rates from California, again, they seem to be doing a little bit better than other high population states like Texas, Florida, et cetera. So this is just something else to be mindful of, is that, you know, California seems to be doing pretty well compared to the other places in the US. It could be argued that as a country, we're not doing as well as we should, but that's a different debate for a different day. Just keep in mind that, you know, these are the kinds of things that at the state level and at the national level, policymakers look at. I'll show you some maps that have caused, I think, more confusion than clarity right now, but this is going to be the way of the future is these are maps from the CDC on this slide and the next slide. This slide shows levels of community transmission. The next slide is going to show you levels of hospitalizations. And here you see that community transmission still remains pretty high, which is very confusing for people because what I showed you in the very beginning of this talk was that community transmission was actually slowing down. So our local data doesn't seem to be lining up as well with the CDC data. And that just has to do with gaps in data and how the CDC counts cases, whether they count them on the day of exposure, on the day of diagnosis, et cetera, et cetera. Eventually, all of this will harmonize. That's what the experts are telling us. And eventually, we will be looking at these maps that the CDC is providing at the county level in order to make in order to make our decisions, or in order for the state to make their decisions. And that's basically to help to really simplify some of the data gathering, because people need to be doing other things besides COVID, and also just to have a national strategy that seems to make sense. So this is one just snapshot. You're going to be seeing a lot of these maps from the CDC because it seems like everyone is starting to use these. The next snapshot is from the CDC that shows new admissions into the hospitals. And here you see a more accurate picture of what really should be, I think, affecting policy. And that is not just the general level of infections in the community, because we know most infections are going to be pretty mild, sometimes even asymptomatic. And most people are going to get better after a couple of days, even if they never enter the healthcare system. So those don't seem to be as impactful on policy changes as, you know, what's going to happen with our healthcare system. If that starts to really be constrained, then we're not going to be able to deliver healthcare to a large segment of our population. And that really does give us pause and make us a little bit more cautious when we lift restrictions like masking in schools, masking in indoor settings and at large gatherings, et cetera. So that's why looking at hospitalization seems to be a better metric for, you know, just how well we're doing and how whether we're able to keep people from really getting sick. What this shows is, you know, again, we're not out of the woods yet, but most of the country is doing pretty well. In California, you can see that new admissions are still kind of a little bit higher than the rest of the country. That, again, may be related to data gathering, how that's done in different states and different counties, et cetera. But this is something else that, you know, the snapshot is probably not as useful as the movement over time. So this is something that we're going to keep our eyes on and our mind on as we move forward. And I have no idea what this state is. Maybe somebody can put that in the chat. Okay. Where does the pandemic response go from here? Well, this is taken from another state slide set, but I think it really lays out a nice summary. You know, I think we're going to see more at-home tests and treatments because that's really the most convenient way to, you know, unburden the medical system, but also help people, give them the tools they need to make good decisions for themselves and their families. Obviously, a reliance on vaccines and really making sure people get their vaccines and their boosters is going to be necessary. And really, you're going to see fewer restrictions and more recommendations, and really having public health take that role, which it has traditionally taken, of educating people and really educating communities and doing more preventative treatment. I really feel like with the whole pandemic, we really never had a chance to do a lot of community education in a way that was productive, but we tried our best under high pressure. But I think that there is a movement now to say, you know, now that we have overcome this last surge, it looks like the numbers are going in the right direction. We have a lot of tools in our toolkit now that we can deploy. And now we just need people to understand what those tools are so that they can start to use them. We're actually underutilizing a lot of our tools, probably because we're not educating our communities as fully as we need to. So we really do need to engage them and educate them in a way to where they feel motivated to go seek out vaccines and the antibodies and some of the other things that I'm going to be talking about a little bit later. Obviously, monitoring for new variants and really not dropping the ball with finding newer threats and hazards with COVID or other infectious diseases as those come up. And then basically just improving ventilation and working on masking and vaccinations whenever we see high-risk settings, high-risk occupations, and high-risk populations that are still going to need that extra support. So I really feel like even though this is a big, busy slide, it lays out what that endemic strategy is going to look like for the state of California. There's going to be less reliance on physical distancing and closing things down, and more reliance on things like vaccination and even ventilation, which we know can help, especially in a crowded setting or in a congregate setting. Just good ventilation can mean the difference between just a couple of cases and a big outbreak where everyone is affected. So all of that, it has been kind of sliced and diced and blended into this campaign from the state called the Smarter Campaign, which stands for shots, masks, awareness, readiness, testing, education, and the last one is called RX. And RX actually stands for all of the medications and vaccines and stuff. So really just pushing the fact that, science is really going to help us in terms of getting through the worst part of this pandemic and really getting into what we know works, which is effective evidence-based treatments and really disproving all of the hoax treatments that are out there. So I think that that's something that as medical providers, we should be really excited about and really take ownership of and really understand that this is on all of us, just like we own all of the other diseases and medications and prescriptions that we are responsible for. We really need to be taking that ownership now during this time and really taking it upon ourselves to learn about COVID from a basic science perspective and really feel comfortable with prescribing the medications that I'm going to talk about because it's really going to be something that is the responsibility will be put more and more on individual organizations and providers and less on the state and the public health side. So the endemic strategy actually involved, not just a clever mnemonic, but there was a lot of stuff done on the back end where the governor and his team were able to go through and change a lot of the emergency executive orders that were in place for the better part of the last 2 years. This is a big, complicated document. I don't expect you to go through it or even to need to go through it. Sorry, I misspelled the executive here, but basically this might be something where if you have a legal question or if you have a question about policy or something that somebody comes to you with, you might want to know where to find this information. So that's the only reason I'm going to include this slide in the next couple of slides. The state actually sent us at Public Health a 3-page PDF, which is just a list of all of the things that got tweaked and changed because these executive orders were changed in the last couple of weeks. And so I'll just share that PDF with you. A lot of it is a lot of legal stuff that, like I said, probably won't be germane to what you do, but there is some stuff that is, because obviously this was put into place because of a very medical health related emergency, which was the pandemic when it first started. And so it just has things in there that might be relevant to your practice, like basically a requirement that a healthcare professional reviews COVID results. That's probably affects every single person on this call. And so you'd want to know exactly what that requirement is. And that basically is in part of what has been described. So there's like 30 odd provisions that remain open, which means that they still remain in place. And then there's actually 52 provisions at the very bottom right of this slide that are being terminated. And I didn't even put that in this slide. So here's the 30 provisions that are still open. It's talking about pharmacists. It's talking about paramedics giving vaccinations. It's talking about different professional licensing requirements, et cetera. I would say look through this if you're in a position to where you're responsible for this information. Obviously, we will be more than happy to work with you if you have a legitimate legal question and you want our legal counsel to help you work through some of these issues. Obviously, your own legal counsel should definitely be involved in those conversations. So we're definitely happy to support you. I just think that this is a good reference for you to keep in mind because this might answer your question, and we'll definitely tell you where to go because they very, very nicely annotated all of the executive orders, where you can find them, and even which paragraph to look at whenever you have that question. So I think that this ultimately is a really useful document that we will be referring to over and over again here at Public Health, just as we try to answer some of these questions and situations as they come up. So that's all I'm going to say about that. I just wanted to just share that that was going on behind the scenes, that this Smarter campaign and this endemic strategy actually has some real legal machinations that are going on behind the scenes. And so, I think all of us should understand what those mean, and in general, moving forward, what's going to happen and what the pandemic response will look like. It will look a little bit different, or maybe even a lot different than what it has looked like when we were in the pandemic mode, as we shift into the endemic mode. Okay, more I think exciting and fun to talk about is the medications. The bottom line is that the state has plenty of all medications except for the Paxlovid, and obviously that's kind of disheartening, because Paxlovid is probably the easiest and the most effective medication of everything on this list. But that's not to say that all of these other things are not useful. They absolutely are. They absolutely have their own advantages, disadvantages, indications, et cetera. And that's why we all need to know exactly what they are and help answer each other's blind spots in terms of using them wisely. So let me just start with, breaking down this table, which is provided by the state, because I know it's a very busy table, but I want you to really understand what it's saying. So basically, you can divide your patients into people that are COVID negative and COVID positive, right? So if they're COVID negative, it means they don't have COVID yet, and that's great. So if they don't have COVID yet, there's still some medications that they can qualify for because they're high risk. And the only one on this list that we really need to worry about is called Evusheld. So if your patient doesn't have COVID yet, but they are high risk because they're immune compromised, either because they have an autoimmune disorder or they're on high dose steroids or some other immunosuppressant agent, there's a long list of immunocompromising conditions. Evusheld is an IM antibody, which acts for a long time. Like when they say long acting, it actually protects them for 6 months. And then they can come right back after 6 months and get another shot. And that basically will protect them. And we know that these patients don't mount a normal response to vaccines. So even when they get vaccines, they may not have that full protection that the rest of us do, which is why this Evusheld antibody was approved. And while we're at it, let's just add vaccines to this list, which the state forgot to do that. But basically, definitely get those people vaccinated, get everybody vaccinated. But basically, even if they're vaccinated and they're immunocompromised, they need to have Evusheld. And there's so much Evusheld in our county. We're actually turning away our weekly allocations. And yet we know that there's up to 30,000 people in Fresno County, population 1 million, that are immunocompromised. So you should find them. You should help us find them. You should refer them. You should get into the Evusheld game yourself. It's not that hard. It's just a shot like any other shot. It's easy to give. I haven't heard of any adverse reactions that happen, provided that the patient selection is done properly. So it's a very safe, effective drug. And all of us need to be doing it because we have plenty of supply. It's really going to help protect those very vulnerable, high-risk people that we want to absolutely keep out of the hospitals. Now, what if people are exposed, like they're a close contact? Well, we used to be able to offer those folks monoclonal antibodies, but there's no approved products at this time because those monoclonal antibodies like Regeneron, there was another one called the bamlanivimab, which basically were useful for a time, but with the Omicron variant, they basically are no longer useful. So right now at this time, there's no approved product for people that are close contacts but immunocompromised. That's why Evusheld is so important, because that will protect them even if they come into close contact with someone who's COVID positive. Okay, so what if your patient does have COVID? Well, provided that they are mild and early in their illness and they don't need hospitalization, there's a lot of options. There's actually up to 5 options that you can offer them. A couple of them are monoclonal antibodies. So there's sotrovimab, bebtelovimab. There's also remdesivir, which is an IV antiviral, but it's basically a monoclonal antibody in the way that it's given, because you have to bring them in and give remdesivir, and you actually have to give it over 3 days. You have to give them 3 doses over 3 days. So those are the 3 IV options for someone who's high risk. You're afraid they're going to end up being hospitalized. They just got COVID. They just got diagnosed, and it's very early in their course, and they're still ambulatory outpatient, have a normal O2 sat. You really need to be offering those folks one of these 5 therapies. And remember that the monoclonal antibody therapies We have a really nice document that shows people exactly where they can go and set up appointments. COVID Equity Project, St. Agnes. There's actually over a dozen different providers doing it. So thank you all for those of you who are doing it, and more of you should be doing it. It's not that hard. This is something that you really just can be doing it in your primary care offices, and a lot of primary care and urgent care centers are doing it. So we just need more and more of our providers to be comfortable offering monoclonals and just making this part of your daily practice, because you never know. The providers that are doing it now may stop doing it in the future. We may have another surge, and we just will need more providers, et cetera. We just really want to be very redundant in our ability to very rapidly and aggressively treat new COVID infections, so that those patients can actually get better right away and not have to end up in the hospital. Then, besides those 3 IV options, there's actually 2 oral options. One of them is called Paxlovid, and the other one is called Lagevrio or Molnupiravir, neither one of which is a great word, but those are the 2 pills. Paxlovid seems to be very, very effective. It has just great data and statistics in the controlled trial that was done in terms of its ability to protect people against serious illness and hospitalizations and death. Molnupiravir is actually still pretty good. It's not as great as Paxlovid, but it's still pretty good. And we have a ton of it available. So again, this is another one of those medications that people are turning down their allocations. The pharmacies and the providers that can qualify to get it have so much on their shelves that's not moving that they're actually turning down their weekly allocations. So please think about giving Molnupiravir, especially for your lower risk patients who still, you're worried about them a little bit. Molnupiravir is a great option for them. All of these, have some qualifications and some precautions that you have to take. Paxlovid, for example, has a lot of drug-drug interactions. Molnupiravir has some issues with possible teratogenicity or fertility effects. So people are asked to refrain from sexual intercourse for a few days to a few months after they get this. But that may not even be that relevant, because people, have such a high risk of being hospitalized that they will definitely, abide by those precautions. And so you may want to just have that conversation with your patients anyway, and just let them know that, this is what you need to do, but this is going to protect you, and I do recommend it. And really, you should be comfortable having that conversation with your patients, and we can help work through any hard cases that you have. But it really is a time we need to take these months in the springtime when we have very few cases to really educate ourselves and be sophisticated prescribers, so that we're ready for these patients when they come in, especially if there's another surge. Now, what's going to happen with Paxlovid? Well, the best case scenario is that Paxlovid will be really increased in terms of its supply, and that we will just have a lot more Paxlovid coming into the county. If that happens, we'll be able to release some of the restrictions that we have on Paxlovid and who can get it. Right now, we're really asking only older patients, like 65 and older, or those that have comorbid conditions. Those are the patients that really qualify for Paxlovid. But, if there's enough Paxlovid in the system, then we would be able to kind of, get rid of all of those restrictions and say anyone over age 12 who has serious illness or a risk for serious illness can go ahead and get Paxlovid. It's a 5-day course. So it's just like a Z-Pak, really. It's a 5-day oral medication, and you can prescribe it. The patient can go pick it up at the pharmacy. And if they take it, it'll help them feel better, and they'll stay out of the hospital. And we'll basically convert COVID from what was once, an ICU illness into basically an outpatient upper respiratory infection kind of thing. And wouldn't that be so lovely? Is that we would basically, then we would truly have an endemic phase, because we would basically have a very effective process for rapidly identifying patients, rapidly risk stratifying them, and then turning around and giving them a very effective oral medication so that they have minimal interaction with our hospital system, with our healthcare system, and we can then use all of those resources to get to all of the other problems that frankly have been kind of neglected during the last couple of years. So that's the big strategy. I think the endemic strategy has a lot of things for everyone to do, whether they're a restaurant owner, a school teacher, or a school administrator, but there's definitely a big part of it that we as physicians and clinicians and clinical administrators need to be part of. And I think that that's really well summarized in this slide. This is what people are going to expect from us. So we need to know what all of these different medications are, how they can be used. And really, if we use them properly, I think we really can protect ourselves from, even if we do have another surge. I'm very optimistic that all of these medications on this slide are going to help protect thousands and thousands of patients. And so, it's just nice to know that there is all of this medication available. Let's talk about vaccines, because this is something that we, again, can be very aggressive about and really need to be working on this today. Despite the fact that all of the numbers are looking better, we still have a lot of room to improve in terms of our vaccination rates. So do vaccines help? Yes, they absolutely do. These are medical miracles in the same way that vaccines have made so many other diseases basically, footnotes in the medical textbooks. That's what vaccines seem to be doing whenever people choose to get them with COVID. We know that cases in the vaccinated and the boosted population are a lot lower, even with the Omicron variant, and they were definitely almost zero with the Delta variant. We know that hospitalizations were a lot lower in the vaccinated and boosted population. So you can see here, the red line is unvaccinated, the blue line is vaccinated but not boosted, and the green line is vaccinated and boosted. And these numbers speak for themselves. Like basically, this would be the billboard that I would put up on every highway in our county, is just to say, look, vaccinations work, and here's the proof. Here's the data from the real world that these will definitely keep people out of the hospital and out of the mortuaries. So basically, that needs to be the message that we really have in surround sound for our community, because there's still that hesitating population, people that may or may not understand how important this is. And I get it that people have logistical barriers, but if people just understood how powerful these vaccines are, we would have a lot more allies in this fight. The Commonwealth Fund has actually gone through and made some estimations, and they basically said that vaccines have saved millions of lives and even more millions of hospitalizations in the first year of their rollout. So again, the return on investment is quite huge, and now people are actually adding up the numbers, and this is now being proven over and over again. In terms of the people that aren't getting the vaccines at higher rates, it's really the very young and kind of this older age group that we can do better with. The 18 to 49 are doing pretty well on the statewide level. So these are statewide data. So just keep in mind that we're not doing as rosy as the state, but this I think is basically a good summary of which groups we really need to target. So it's really the school age populations, the 5 to 11 and the 12 to 17. They're in really low numbers compared to where they could be, especially the 5 to 11. There's only about 30% of them vaccinated, and I think it's only 20% in Fresno County here that are currently vaccinated. So we really need to do better about vaccinating school-age kids. I know that parents have concerns. I really think that if they heard from us in a one-to-one conversation that was compassionate, empathetic, and really laid out the science of how safe these vaccines are and how much good they're doing at all populations and age groups, I think parents would really be convinced. I understand that they may have some skepticism about government agencies coming in and doing mandates, and certainly that's natural. But I think people do trust their doctors and their pharmacists. And I think that if we just really take the time to have these conversations, we can really increase our vaccination rates. And we need to be doing it. We just absolutely need to take advantage of this lull that we have to really improve our vaccination rates. So just keep in mind the 5 to 11 and the 12 to 17-year-olds, we really need to reach out to them and get them vaccinated, especially before the next school year, because I think it's going to be a requirement at the state level, although that hasn't been quite finalized yet. And the rest of the population that's kind of hesitating, that may not understand really what this slide shows. I don't think we've done a good enough job at the level of government and policy to really explain what this slide actually shows. Because if people understood just these curves, I think they would understand the power of vaccines. I really hope that when you give people the right facts and help them make their own conclusions, that's really the best way to educate people. And I think that if they understood these are what vaccinated people get in exchange for getting vaccinated, I think that they would rush to go get a vaccine. That's really all I have. I'll look at the comments from the chat and see if you have any questions. Feel free to unmute yourselves and let me know if there's any other questions that you want me to answer. I'll look at the chat right now. Okay. Has the guideline for healthcare providers who is fully vaccinated that test for positive for COVID still the same? Quarantine for 5 days and come back to normal, come back to work if no more symptoms. Yeah, that guideline hasn't changed. What we do, the 5 days was for when you had very limited resources. So if you just have staffing shortages, you can do a 5-day quarantine and then a test. And if the test is negative, they can come back if they're a close contact. What you're asking about is someone who tests positive for COVID. And unfortunately, that isolation period has not changed. They're still recommending a 10-day isolation period for that person and come back if they're asymptomatic. It can go down to as little as 7 days, but only if you have staffing shortages. From what we're hearing, the staffing shortages are really not there as much with the surge abating. I know that is probably not accurate for some of you on this call, but keep in mind that the best thing to do is to quarantine someone or isolate someone for 10 days if you at all can. That's really the safest thing to do for a safe work practice. We understand that you may need to bring people back earlier because of staffing shortages, like I said, but really 10 days if they have COVID is still the absolute minimum, and they can come back earlier if they're a close contact, but it's still better for them to quarantine. Does Fresno require temperature checks? No, we don't. We just require just a kind of like a checklist or a check-in process. It can be done online. It can be done through an app or a website, but the temperature monitoring is super low yield in our experience. So we just don't require temperature checks as long as people feel well and they don't have any other symptoms and they're not a close contact. And then someone is asking, a study came out that said that the vaccine was shown to be not as effective in the 5 to 11 age group. Yeah, that's a good question. It's interesting that the studies for the 5 to 11 were started during kind of the pre-Omicron days. But then obviously Omicron, we know that the vaccines are not as effective in the era of Omicron, just because it was a really sneaky variant that evaded some vaccine immunity. And at the same time, that was the same period of time when the 5 to 11 age group really got approved for their vaccine, was last fall. So I think that there's several factors there. I think that really you'd have to look at the real world data to say, did this vaccine protect against Omicron? And if it didn't, then that's not as surprising because, we saw the same thing in adults. So that may be where people are getting confused to say that the vaccine doesn't work in kids, because it got released at the same time that this newer variant came out. And so the data might be a little bit muddled. But beyond that, I haven't heard, that it's not as effective. I mean, it certainly seems to be working. We know that the children's hospitals are telling us that the vast majority of their hospitalized kids are not vaccinated. And so they seem to be trending in the same direction as the adults. So that's why vaccination is still recommended in that pediatric age group. And then Kelly's asking about Cal OSHA requirements. And yeah, you know, I wish I knew how to harmonize all this stuff. I mean, Cal OSHA has a section for healthcare workers, and then they have a section for non-healthcare workers. And the stuff for non-healthcare workers is really changing quickly. And in fact, it has a lot to do with, you know, how they're going to do schools and things like that. With healthcare workers, I don't think that they're going to change much from what they've already got in place. We're not hearing about much change happening in terms of, you know, will we ever get to take the masks off in a clinical setting? And the answer right now seems to be no. We haven't heard that you can, but you know, obviously this is moving, and so in the future they may consider that if the numbers get really low. But I think right now they're still asking for, you know, an increased level of precaution in the healthcare settings for obvious reasons, including masking and some sort of entry level check for COVID. It doesn't have to be a temperature check, but it does have to be, you know, you have to screen your employees to make sure that they're not walking with COVID and going to spread it in your workplace.
Can I keep going off of that one?
Yeah, go for it.
I'm curious how many other health centers are still doing the like a greeter station at the front when they come in, or do you just do that screening through your front office staff when they get to the desk? We're just trying to figure out how to get into that endemic stage, right?
Are you talking about for patients or for
patients? For patients.
Oh.
With the employees, we can still do that through the back when they come through. So
yeah, I'll let other folks discuss what's been successful for them. I mean, it could be simple as like a clipboard with a form that the patient just fills out. If you don't want to dedicate a staff to asking those questions. It can even just be a big poster that says, if you have these symptoms, then we ask that you postpone your appointment. There's lots of different ways to do it, I think, and still meet the requirement.
okay.
The screen.
Yeah, because we got some temporary employees for that position, and you know, it's costly to have employees that don't have a huge role.
Okay. Janelle is saying at Fresno State they still screen patients. So possibly with like a quick verbal interview. A couple of folks are saying they're still screening their patients.
Thank you.
Sure. I think it's good to, you know, have some kind of interaction, but then also offer masking right then and there, like right at the front door. Because, you know, obviously some people forget their mask. I do that half the time. And then if you have someone that's asking the question and offering a mask, that's just a good 1-2 that takes care of, that really helps your infection prevention program, right? I mean, so it may be worth continuing that process. Sometimes people, you know, they're not as compliant if they see just a sign or a poster. Whereas if they have to interact with a human being, then obviously there's a lot more compliance there.
Right, and I don't expect masks to go anywhere in healthcare for a long time.
Yeah.
But certainly as they get relaxed other places, there's a lot more pushback from patients, which is where that face-to-face interaction can catch it sooner.
Right. Yeah, no, I know. It's still getting worked out. You know, we're hearing from both sides about the masking debate insofar as it is a debate. But we know that the less masking that's required in every other sector, the fewer people just will remember to take a mask when they walk out the door, you know? I mean, I think it's just human nature. They're just gonna stop buying masks, stop using masks for most of their activities. And then whenever it's time to have a healthcare encounter, they're just not gonna have access to a mask readily in their car or whatnot. So that's where it's almost going to be expected that, you know, offices and hospitals and stuff provide masks for people. All right. Well, those are great questions. Keep them coming. Email us if we can help you with anything, and let us know if you need us to elevate any of your questions or concerns. We certainly want to be a support for you, and hope that you're able to take some time to rest and recharge, and continue the good work that you do. I think we'll go ahead and end there, and we'll send out these slides and that PDF of the executive orders right after this call. Thank you so much.